Traditional bunionectomies have often required a lengthy recovery, minimal walking and being inactive for months. In contrast, Dr. Selner's tricorrectional bunionectomy, which has changed the lives of so many people, is an outpatient surgery. Most patients are up and walking right away and are usually back in shoes in 2 to 3 weeks. Dr. Selner and his staff have enabled hundreds of their patients to return to their normal activities.
Well, I just talked to Ken, business manager in the office, and he called up the insurance company and got all the approvals for it, and so it was a piece of cake.
Now there's no reason to suffer unsightly feet, the pain, the calluses, leg fatigue and back pain brought about by bunions. It's no wonder people from more than 30 states and 5 foreign countries have come to MedStar to receive that special approach to bunions.
When I was in school and seeing everyone else's procedures, his is by far the best.
I see the procedure performed many times, and I see the results, and I see the surgical technique and the planning involved in the procedure, and I think it's a very refined, upgraded bunion procedure.
Dr. Selner is probably one of the most foremost authorities probably in the United States, certainly in the state of California, in the area of bunionectomies.
It's common for patients to be apprehensive about surgery, and that was certainly true for Martha Contreras. But there's no reason to be fearful. With a combination like Dr. Selner and his staff of professionals, patients deserve and receive absolutely the best care available, both surgically and emotionally. Let's check on Martha's progress.
Martha, we've gone over all these technical details, but the most important thing I want you to do is not to worry.
Martha, like so many of my patients, was just afraid. She had had friends who had bunion surgery, and she was very apprehensive. She had heard that bunions are terrible surgery and she wouldn't be walking for a long period of time, and that it was going to be difficult for her, and she'd be on crutches and all the other things that people hear all the time.
That you had to put a cast, that it was really painful.
She's going to be in for a big surprise of how easy it really is.
Now that all the fears have been allayed, it's time for the next phase of the procedure, diagnosing the scope of the problem.
When we looked at Martha's foot, we knew she had a bunion, but she didn't just have a bunion. She has hammer toes, she's got calluses on the bottom of her foot, and her arches roll in. Because we know all of that, what's very important is to look at her future. We want to correct that bunion, but we also want to stabilize the way she walks. We ran an F-scan test, and that test measures the amount of pressure on all the bones on the ball of the foot. No doctor can see that. You can only measure it. So when you watch somebody walk, when you examine them sitting in your office, that doesn't answer the question, what happens when she's walking? And with that technology, I began to think of a new way to re-engineer the joint. Instead of removing a bump, how do you re-engineer and reposition that joint so you neutralize all the abnormal forces?
MedStar is doing things that are on the cutting edge of medical technology, as evidenced by their movement analysis lab.
Traditionally, bunion surgery has always been difficult. If you talk to most people that have had bunion surgery, the common theme you'll hear over and over again is that it's painful, the bunion comes back, and nobody in the right mind should get their bunion done. That's commonly what happened. And so what came out of all that is that people started developing these what we call quickie procedures. When people are expecting these quickie surgeries to give them an answer, they don't check the doctors out. They don't check to see if the doctors have published clinical studies. They don't get a list of 100 or 200 patients that a doctor has done. They don't ask the doctors, what hospital are you involved with, and are you involved with a teaching program? These are all important questions. Why would you have surgery without checking out how many the doctor's done, how happy are the patients, and everything else that's important?
Well, hi there. Good morning.
Good morning.
How you doing?
I'm doing great.
Ready to go?
I'm ready to go.
This is the great and talented Dr.
Nice to
Selner.
meet you.
This is Dr. Bunch, my resident.
Nice to meet you.
We work together. We're the tag team, okay?
All
We're
right.
brothers and we fight all the time, but we're great together in surgery, okay? Now, any last questions you have before we go?
No.
I guess we covered just about everything you can say about bunions. There's nothing more you want to know, huh? Do I get a high five?
High five.
Okay, let's go.
Okay, high 10. There you go.
Most bunion surgery used to be done under general anesthesia. By general anesthesia, we don't just mean sleeping. What general anesthesia is giving you enough of those powerful gases and other medications to suppress your breathing. You can't breathe on your own.
They're going to be getting mostly local anesthesia and a little twilight to make them sleep through the procedure.
The following scenes contain graphic images of surgery. Viewer discretion is advised.
Here's how we perform the tricorrectional bunionectomy. First, we release the soft tissue. Then, we place 2 cuts on the side of the metatarsal bone so that we can slide the bone over. Now, a pie-shaped wedge is removed from the top of the bone so the cartilage can be aimed directly ahead so the joint is lined up properly. We then can rotate the cartilage, slide the bone over, and while we're sliding that bone over, it also drops down. And that completes the 3 different corrections for the tricorrectional bunionectomy. Once the bone is moved, a pin is temporarily placed through the side of the bone to hold it while the screw is placed into the osteotomy. When the screw is placed in, it is stable and will hold the bone while it's healing. Screws are generally removed 3 to 6 months later. Finally, the degenerative bump, which is the actual bunion, is removed.
Now that we understand what Dr. Selner is going to be doing, it's time for surgery.
Most bunions are done with a lot of surgery. They make a big long incision on the top of the toe, and that big long incision, they do dissection on both sides of the joint. All that trauma creates swelling and pain. We work entirely within the joint. We don't go outside that joint. And because of that fact, there's much less trauma to the tissue.
My husband had a bunion for many years. Since I've known him, he's had terrible bunions, both feet. His mother had bunions. And of course, like any other patient, he was afraid to have surgery. Finally, after I nagged him long enough, he said he would go see Dr. Selner. He went for surgery. It was everything that was promised to him and swears by the surgery.
Now let's see if we can open that joint up. Okay, now you can see the arthritic changes. The pink here is where the bone is all eroded. You can see all this bumpy surface on the side. This is the true bunion. What I'm going to do is line this cut up here right near the front of the bone. But by raising my wrist up in this direction, I'm going to angle the cut downwards. That's important so when the bone slides over, it doesn't just slide that way, it also slides down. So this is a multi-plane cut, and it has to be done just right or the bone won't line up correctly. Here we go. Next cut, what I'm going to do is, if I make the second cut, which is the top cut, there's 2. There's a low cut and there's a top cut. If I aim it slightly forward, when the bone slides over, it'll go forward. So we can try to maintain the length as well as dropping the bone down at the same time. How does that look, Mark? Now I'm going to make a cut at an angle. And so what's going to happen is we're going to take out a wedge out of this bone. When we remove that wedge, the cartilage, which is facing in this direction, will rotate ahead and go from this direction to that direction, so the good cartilage will be lined up. The wedge was sitting right in here. Then if you see, the wedge is wider on that side and narrow on that side. Okay, so now what we're going to do is we're going to slide the bone over. Okay. Now can you see where it's been slid over? It used to sit here, now it's moved over here.
With the bunion deformity, once the structure or the bone has been realigned, right on the table the toe goes straight.
What we're going to do now is we're going to stabilize the bone with a temporary wire. Go ahead and mark this. And what we've done now is we've held the bone tightly, so now the bone is in its new position. This is a special type of screw. It's called a cannulated screw. So what we're going to do is we're going to place this temporary pin in. The screw has a hole in it, and that screw will track right down this wire. So we can use this as a guidance system. We can place this exactly where we want this wire, make sure it lines up correctly before we put the screw in.